Good evening. It is always a pleasure to hear from Shashank Joshi sir. There is no conference without him. Today, he is giving the keynote address on salt sensitivity. I will hand over the mic to introduce Shashank Joshi sir.
Our speaker is Dr. Shashank Joshi. He is an endocrinologist from Mumbai. He is a Padma Shri awardee, past chair International Diabetes Federation Southeast Asia, president Indian Thyroid Society, past dean Indian College of Physicians, past president API, and emeritus editor JPEF, and Indian Academy of Diabetes, and he has various positions to his credit. So over to Dr. Shashank Joshi.
Thank you so much for kind words, Chairperson. So I'm talking today on salt sensitivities and salt matters in modern hypertension therapeutics. And we all know that if there's a single pertinent risk factor, which is lifestyle for hypertension, sodium or high salt intake is right up there. But the term salt sensitivity is ill understood. What is salt sensitivity? It is significant blood pressure response to dietary salt changes. And around 1/3 of healthy individuals and 50% of hypertensives have salt sensitivity. The prevalence in India has not been well studied. Some of us work in this area, but it's very ill published. And it's more common in people with metabolic syndrome, type 2 diabetes. That's how we know it. Georgie is coming up next in his oration. CKD, they see a little of it. African Americans behave differently. We know the ACE response is different. They behave differently to salt. And elderly people behave differently to salt. So clearly when there is excess sodium, it impacts health and blood pressure. And it impacts cardiovascular risk. So clearly we see that there is an exaggeration of salt response in salt sensitive individuals. And now the American Heart Association, American College of Cardiology, recognizes salt sensitivity as an independent risk factor for cardiovascular disease and mortality. The mechanisms of salt sensitivity are very complex. They are renal, vascular, immune, even gut microbiome. And fundamentally, when there is an impaired response of salt sensitive individuals, there is a reduced peripheral vascular resistance and nitric oxide production. And the net result is elevated blood pressure in response to high intake. However, should we make it zero salt diet? The answer is no. This is a meta-analysis of 23 clinical trials of sodium restriction in insulin resistance. And you can see that universally we have been recommending low salt diets for lowering blood pressure. But the unintended consequence of zero salt diet is worsening of insulin resistance, which is associated with low salt intake. So the lack of sodium, what happens? It increases the insulin levels. There's a compensatory mechanism to retain sodium. Also, the low salt diets elevate stress hormones and cause vascular stiffening, vascular and systemic insulin resistance. And remember, in the coastal parts of India, which geographies we live, we also sweat a lot, and there is sweat chloride. So remember, just like too much of salt is bad, too less salt may actually increase mortality and cardiovascular events. So we need to have sodium and salt just right. And this was the data set they analyzed in their meta-analysis, McKeef et al. There were double-blind studies where they had normotensis with high blood pressure with moderate salt restriction versus normal salt intake. And clearly you could see the moderate restriction of salt aggravated systemic and vascular insulin resistance and no reduction in BP with low salt diet. Then there is not consistent data even in RCTs to suggest that low salt diet actually raises insulin and blood volume depletion with no significant reduction in blood pressure. And this the data keeps on building in this population. For brevity of time, I am not getting into that. But one thing is very clear cut, that low salt diet induced insulin resistance is very well known. It activates sympathetic nervous system, renin-angiotensin system, volume depletion, a lot of nephas and low sodium restriction. And the result is worsening of insulin resistance, just like statins cause diabetes and they worsen insulin resistance, worsening of lipids, uric acid, viscosity and kidney function, and activating sympathetic nervous system and RAS system. So they concluded very clearly that sodium restriction below a particular amount should be used cautiously, and you need to have a diet which is in whole foods which maintain normal sodium intake. That's a better impact on metabolic profile. But the data worldwide is not showing so. Cardiovascular mortality attributed to sodium consumption is huge. In the global burden disease study, excess salt is the 7th leading cause of mortality in South Asia, though it's worldwide 11th leading cause, and we see a lot of deaths because of that. Because we eat too much of salt. Highest salt is North India, 14.13 grams. It's too much in excess. South 9.8, East 10.12, and West 9.38. So we are having too much of salt. And that's the biggest problem we have. So our salt intake exceeds the physiological intake by 5-fold and 6-fold compared to the natural diet. And all that is coming from processed or pre-processed foods. And that is all the restaurant foods, the Swiggies and Zomatos of the world. The naturally occurring salt on the table salt in the home cooking preparation is very, very less. Intersalt study, which also clearly showed that the 52 communities worldwide, the blood pressure with age-associated salt intake was very, very well recognized, and that's something we recognize. But one thing is clear-cut: as human beings, there is a threshold of variability of blood pressure response to salt, which is salt. Some are salt resistant, some are salt sensitive, and there is a new term in blood pressure biology called impaired natriuresis. Fundamentally, this is a pressure natriuresis constant which salt sensitivity regulates. And fundamentally what's happening in that is there is increase of sympathetic nervous system activity, there is increase in total vascular resistance, and thereby increasing the blood pressure with the sodium and volume retention which we see. So salt, water and blood pressure clearly are impacting hypertension, and there is a shift of the curve from normotensive to hypertensive, because we all know that the kidney pathogens of hypertension has genomic susceptibility. When there is high sodium, low potassium intake, the normal kidney maintains arterial pressure in a normal range, normotensive range, and there is a shift of the pressure natriuresis shifting to the right, and you get impaired renal sodium excretion. So clearly salt resistant subjects, the pressure natriuretic relationship shifts to the right without a change in the slope, and in salt sensitive subject the slope is declined and higher blood pressure levels are required to maintain the sodium balance through increased sodium excretion. So you can see the differential of the curve between salt resistance and salt sensitive subjects. That is why salt sensitivity is important and diuresis is important. So this impaired natriuresis is seen in multiple conditions, with age, with salt sensitive hypertensives, uncontrolled hypertensives, non-dippers, nocturnal hypertensives, insulin resistance, visceral adiposity, CKD or renal insufficiency and heart failure. We recognize that very clearly. And that really leads to a lot of resistant hypertension. We all recognize this, vascular contraction, sympathetic overactivity and the sodium resorption. So clearly we now know that impaired natriuresis is linked, and we just had a sleep talk from Dr. Muruganathan just before this, will lead to obstructive sleep apnea and various other things. And that little diuretic can actually make the switch. So clearly we recognize that impaired natriuresis in insulin resistance is also very, very well recognized. In fact, in 2010 itself, the American Heart Association recommended that people with heart disease, including people with type 2 diabetes, should limit their dietary sodium to 1.5 grams. Because we know that high insulin levels enhance sodium retention in the kidneys. And therefore, when there is obesity and RAS activation, there is impaired natriuresis, and impaired natriuresis also leads to the CKD risk and the CVD risk with that. And we also know impaired natriuresis is directly related to heart failure. And we know that this is something which is very well recognized there. So there were now old concept of salt sensitivity and new concept of salt sensitivity. The shift to the graph going on the right is very well known. So the first theory which came out was kidney centered theory. Second theory which came out was the vasoconstriction theory. In the kidney centered theory, they said high blood pressure allows the pressure natriuresis to match sodium excretion with intake. So intake is not equal to output due to less number of nephrons. Whether it's aging, female sex, low birth weight, small for gestational age, hypertensive, CKD, low potassium diet, African ancestry, low renin statins, and even genetic variants in the enhanced variants. So this was the traditional theory of salt sensitivity, where the number of nephrons are less. And the newer theory is the vasoconstriction theory, which is high vascular resistance. High blood pressure is a consequence because of the incapacity to vasodilate after a sodium load. This is classically seen with endothelial dysfunction, the perturbed endothelial glycocalyx, the high vascular sodium milieu, inflammation, and disturbed sympathovagal balance. And that's why some of our modern therapies are useful here. We all know volume loading and vasodysfunction are theories of salt sensitivity, and I will not dwell into details of that. And we understand more and more now on the mechanisms of salt sensitivity and salt-induced resistant hypertension. There are a lot of genomes and genomics which predispose to salt sensitivity. There are genomes which are involved in altered renal sodium transport as well as vascular reactivity. And these genomics are very well known. We also recognize there is an epigenetic modulation in the fetus and the elderly both. And that impaired renal handling in salt-sensitive hypertension is also well understood. We also know that there is decreased bradykinin in the salt sensitivity system and enhanced sympathetic nervous system activity, which causes cell sensitivity. So clearly there is an excess sympathoactivation in salt-sensitive hypertension, and there is data. Does it impact outcomes? As cardiologists, they like to have outcome studies. So this is a Japanese study, because we know Japan is a salted country. They have the highest incidence of strokes in the world, and United States. And if you see the CV curves of Japan and United States, you can clearly see that this study from Japan shows that salt sensitive people have more cardiovascular events compared to non-salt sensitive. And if you see the US curve, salt resistant people had a greater survival than those who are salt sensitive. So clearly you can see data from US and Japan. We need to generate our own science and data that it matters. And it's linked to peripheral vascular resistance. Urinary sodium to potassium ratio is now also emerging as an important tool, is self-monitoring. Because you can self-monitoring urinary to potassium ratio 3 times per day as an effective low salt intake can be useful tool. And this is being studied in Japan, and that's how they did the Japanese data. In South Asians, and we have a nephrologist in the audience who will give an oration, the role of salt intake and salt sensitivity is very well studied. And clearly we see that it impacts. We have seen the data with DASH diet. We have seen the data in different human and animal studies on micronutrients on salt sensitivity, like using potassium and several other agents. And we have also seen macronutrients, dietary changes, alcohol on the salt sensitivity. So now AHA and ACC recognize salt sensitivity as a marker for increased cardiovascular risk. They also know that current recognition techniques for salt sensitivity are impractical. But the strategy is sodium reduction, but not zero sodium. The response could be variable, and you need to add some agents which may be modified. Currently, there are no guidelines for impaired natriuresis. There is a consensus to reduce salt, and diuretics and thiazide-like diuretics combined with CCBs are the most effective drugs of reducing blood pressure in this population. Clearly, the role of chlorthalidone is extremely well recognized in this regard, and we also know that CCBs cause natriuresis by dilating the afferent arterioles and GFR. So that is something which we recognize. SGLT2 inhibitors also have been postulated that they may be acting through this route. So when we look at treatment of salt sensitivity hypertension, though there is no standard therapeutic guideline, WHO also recognizes that it's an important tenet beyond reduction of salt to use a little bit of diuretic. And that's why if you look at the old studies of hypertension, every time when the JNC guidelines came out, they always put diuretic right up in the pecking order, and various meta-analysis very clearly showed that these drugs worked. We clearly recognize the sites of sodium resorption and diuretic action in the nephron, and we clearly recognize the role of diuretics in salt sensitivity, low renin hypertension. And therefore the drugs like chlorthalidone have a clear role. and they are particularly effective in our population, including the diabetic population. So thiazide-like diuretics versus thiazide diuretics. Thiazide diuretics are not used anymore. We look at thiazide-like diuretics and they have a clear role. And that data again, the case for chlorthalidone has been illustrated first by our nephrology colleagues, and now of course we have better data in public domain as well. So clearly when we look at hypertension management guidance in adult CKD patients, that role is very well documented. But you saw from 2022, 23, 24, all the guidelines started going beyond ACE, ARB and CCB and adding a diuretic there. And the beta blockers more or less moved out of the picture. You can see the ESC, you can see the diuretic right there, and mainly in the true resistant hypertension, diuretic right came up in the pecking order right on the top, and you could see in CKD stage 4 and 5, you could see the addition of chlorthalidone as well. ADA also recognized it, because as endocrinologists and diabetologists, we don't tend to use beyond ACE, ARB and CCB's diuretics, but you could see right up there with ACE, ARB, CCB diuretics got added. And of course, our own guidelines from India, which are the RSHDA guidelines, also looked at thiazide-like diuretics and chlorthalidone for a superior blood pressure reduction in patients with resistant hypertension. And WHO already had put this as a first-line agent. Thiazide and thiazide-like diuretics, ACE and ARBs, and long-acting CCBs. And clearly the rationale of that thinking is linked to salt sensitivity. And again, the ABCD algorithm, younger patient, traditional algorithm was a beta blocker, and A and B, A was for ACE or ARB, C was basically for CCB, and D was for diuretic. But that step is getting more and more blurred, and the D is getting right there. Of course, the last JNC came out in 2014, and they clearly recognized the role of thiazide type diuretics with the CCB. So I thought what I wanted to give you and highlight was salt matters, reducing salt intake to 5 grams matters, but making it zero salt will make you faint and actually proliferate insulin resistance. And number 2, in your antihypertensive regimen, think of salt sensitivity when you are treating in India, when you are treating a type 2 diabetics, and don't forget a thiazide-like diuretic like chlorthalidone. Thank you so much for a patient hearing.
Thank you, Dr. Shashank Joshi, for the exciting talk. Open for discussion, questions.
Sodium reabsorption. I think he got. Okay. Whether insulin resistance increases sodium reabsorption.
Sorry?
Reabsorption
Does insulin resistance
increases sodium reabsorption.
Yes, it can. And it will. But salt restriction aggravates or insulin resistance or causes insulin resistance.
That is why diabetic hypertensives are more salt sensitive.
That's right. That's right. Because what happens is when you restrict sodium, you are activating both sympathetic nervous system and renin-angiotensin system as well as volume depletion. The intracellular sodium concentration will increase with the glucose absorption from the intestine also. So you are absolutely right.
If there are no questions, we can conclude the section. I thank organizing committee to chair for chairing this session. Thank you, sir.
Thank you, dear Chairpersons and Speaker, for helping us appreciate the salty details behind blood pressure and diabetes care.